Thank you. How do I pronounce your first talk? First name,
Sarah.
your last name.
Last name Preum.
Preum.
Yeah. Thank you. And I'm planning for like 40, 45 minutes.
Perfect. Yeah. We do ask questions throughout.
Yeah, that's okay.
But we have no Russian mathematician in attendance. We normally have a Russian mathematician, so all bets are off. That's why we got to laugh. The network scientists know about. All right, so why don't we start? Thank you all for coming. I know this is the second talk that the Institute has up today, so we've been very busy. It's my pleasure to welcome Sarah Preum. She is an assistant professor in computer science at Dartmouth College, and she also serves as a technical associate director at the Dartmouth Center for Precision Health and AI. Her research combines natural language processing, big large language model. At this point, it seems like the equivalent. I'm not sure, but I still know what parse trees are. So young kids don't know. Deep parse trees and shallow parse trees. Her research combines natural language processing into computer interaction to tackle challenges in computational healthcare. And she has many papers in top venues like AAAI, GCL, EMNLP. She was a postdoc at Carnegie Mellon before she started her assistant professorship. She was recognized as a Rising Stars in EATS in 2020, and she got her degree at the University of Virginia, as I understand it. And of course, she's had numerous grants to do this work. So thank you very much for coming, and I'll turn the floor to you.
Thank you so much, Tina, for the kind introduction. Welcome everyone to this beautiful afternoon. I'm so happy to be here. I had a wonderful time today talking to different people here at the Network Science Institute. Thank you so much for being so welcoming. And I'm really excited to share my research with you today and get your feedback. So let's get started. So my research focuses a lot on communication, and communication is fundamental. We need communication for making meaningful connections. One of the greatest treasure in life. We need communication to, for our job even. I feel like as a professor, it's kind of my job depends on it. So communication is super important, as we all know, but there are also times where we struggle with communication. For example, in the past week, so did you ever feel like, I wish I communicated differently, or, things like that? That happens all the time to us. And there are all these gaps that often makes communication challenging, even though we do it every day, many times. For example, often there are information that are being shared that are implicit. There could be information that is missing from the communication that we are maybe not aware of. There could be scattered information, you have to go back and remember something. Another challenge now with so much content, information overload, how many papers are coming out, so many different things to remember. And of course, with all this information and generative information and all this underlying technology, there is this increased risk of misinformation in online space as well. So in my research, my focus is how to leverage AI, specifically natural language processing and human AI interaction, to address these gaps in communication. And as an application area, I particularly focus on health-related communication, because I personally feel like health communication can actually save life, or the other way around if there are gaps. And it can improve health outcomes and productivity overall. So that's where my research lies. And today I'll be discussing a couple of projects that we have been working at Dartmouth in the last few years, and kind of our takeaways and directions for future from that. So particularly for health communication, we already know about these challenges for communication, but particularly for health communication, there are additional challenges. Like many people today asked me, okay, you work on healthcare data, so how do you get access to the data? How do you make sure that privacy is preserved, or like addressing this ethical concern? Another challenge I have faced drastically in the last few years is also with labeling or annotating data. For example, the particular problem I'm interested in, there is maybe no label data set. And often labeling data is very, very expensive and very, very time consuming. That also makes some of the solution or design choices we make to come up with a solution more constrained, given these challenges. Another challenge could be, how do you encode opinions of experts? Like, you are trying to design decision support system for providers, clinicians, but that means the system need to capture their thought process, their decision-making process, which is also super challenging to abstract, those thoughts and ideas into models. So all these challenges make analyzing or improving health communication further complicated. So as a solution, like as a tool for solution, we consider in-context learning. And I will briefly share what in-context learning is, and then I will show how we develop in-context learning methods for our particular research question. So in-context learning is a method where you use a language model or a large language model to learn a task, but it's very nice because you don't really need a lot of training data to do that. All you do is basically give the model some demonstration, some example, so that it can figure out what's happening, what needs to be done. And then you share that example using some sort of natural language template. So this is what it looks like, the in-context learning, if I had to abstract it. So for example, you have this label data set here. This is like a sentiment classification data set. So you have some inputs and there are labels indicating positive versus negative sentiment. So to do in-context learning, at first you need this template, like how you represent the input sample. And then you basically select K demonstration example. So K is something you figure out later how many samples you want to share with the model for inference. And then you pass it to the model. So you give it the context. That's why the name comes, like in context. So you give the context and then you give it a sample that like you want the label from, you want the output from the model. And then the large language model makes an inference on that sample based on the demonstration you have given to it. But what's interesting about in-context learning is all the parameters are actually frozen. We are not changing any model parameters. The model parameters are frozen, but then you are kind of giving the model some context to make an inference on the fly. And that's why it's actually very interesting to apply in healthcare research, because you don't need a lot of data to pre-train or fine-tune the model. You can kind of come up with sample. But as you can imagine, there is trade-off, right? Like how do you come up with this good sample so that your model is doing well? So that is something we will see later today, like how in-context learning particularly works for the health communication task we are focusing on, and what are some avenues to make it better for the future.
So the context is coming from the template?
Yes, right? The template. Yeah, the template. Exactly. Yeah, template and the samples you choose for demonstration.
And,
yeah.
I'm not, as you said, I'm not changing any of the parameters, so I'm not doing any training.
No. Right.
But I'm assuming that the trained model has seen something around that context, right? Like, what are some of the assumptions that are being made?
That is true. Like that is one of the assumptions that in context learning would work if it's like the samples you choose, they are representative of the trained data, or it has some sort of knowledge. And for in context learning, actually in this survey paper, they kind of tie, like this is an open research question, like why in context learning actually works. So there are theoretical framework where they kind of compare it with Bayesian inference, but there are also functional approaches where they see like the attention module really plays a big role. So like why in context learning works. Yeah. But this is getting like a lot of excitement in general, in like NLP community and also in health community because of the flexibility it has. But again, it's also like an open research question.
So does it have links to like, now I'm becoming that Russian. So does it have links to like prompt engineering in a way?
It does. Yeah. Okay. Yeah. It's definitely relevant to like prompt engineers to some extent. Yes. Like how you are constructing the template, which samples you choose, how many samples you choose, the order you show the samples, they all actually matter. And there are like active research areas, how we tweak all those things to come up with a good in-context learning model. Yeah, of course. Okay, so this is the outline of our talk. Like that's how I plan to spend the next 30 minutes or so. So we will be actually covering 3 high-level research questions. The first one is how in-context learning can improve patient-provider communication in formal healthcare setting. Like, you're talking to your doctor, you're sending them a message and they're getting back to you. The next question, we will kind of go beyond traditional care settings. So for example, what happens in a patient forum? Like, there are many, many online patient forum, and how can we use AI to improve communication there? And throughout these 2 questions, we'll also see some new methods and measures we have developed to evaluate large language models for this type of task, and what are some gaps. And then in the third question, as time permits, we'll kind of share some ideas about how to improve in-context learning for this kind of challenging task. And I promise, I will share stories so that it's not too boring. And feel free to ask questions as well. Okay, so my first research question will start with the story. So this is a story of a nurse provider. Let's call her Mary. And one of the tasks nurses have to do is actually in their inboxes. So they have inboxes where patient can send messages, just like, you get emails from your professors or your mentors or colleagues. So they have these inboxes, and patient can message them if they have new symptom or if they have any question. So one of the tasks they have to spend daily several hours on is basically sorting and going through this inbox, like which message requires responding right now, triaging those messages and coming up with the responses. And doctors also have to do it, so, and this is a very time-consuming task for them, because this task is not really very straightforward. For example, maybe she opens her inbox and there is this message from a patient saying that, oh, I had some cough this week. Should I be concerned? So this message is pretty brief. So now she's thinking, oh, does he have a runny nose as well? Does he have fever as well? Because the patient didn't mention it in the first place. And then often they also have to look through the electronic medical record portal or EMR portal, where information is very fragmented and information is very scattered. So it kind of goes back to the problem of information overload and also scattered and implicit information here and there. For example, what are some of the prior diagnoses this patient has? Because many of the responses might depend on their prior diagnosis. Now, for example, many times they actually completely flip their decision based on whether they have like a cancer diagnosis or some other diagnosis. So many decisions might change. Another thing is like what medications they are on. So their decision also depends a lot on those other factors that are scattered and implicit. And then what happens is often there is a lot of missing context in that messages. And then they have to call the patient. And if the patient is anyone like me, the patient doesn't pick up the phone or is not near the phone. So then they spend a lot of time is wasted to kind of fill in that missing holes in that communication. And then eventually once they have all the pieces, they can come up with a triage decision or a response and get back to the patient. And while all of this is happening, the patient might think, okay, I sent a message 2 days ago. Where is my doctor? Why isn't anyone getting back to me? Right? So this is a very challenging problem that providers are very burdened with. And I actually work with many providers and nurses at Dartmouth on this problem. And every time we talk about this idea, their eyes light up. They're like, we need this, and this is just for one patient, but there are like thousands of patients with the hospital system with many, many different conditions. So there is this huge cognitive overload with this particular problem. And this is a very challenging problem. And this is why we pick this problem, because I think this is a nice ground for human AI interaction, because in no way we can replace triage nurses and doctors now, but we can definitely augment their capability. And all this time that is actually spent on this communication process, this is time away from patients. I actually had doctors narrating their personal experiences, like, I wish I could spend more time with my patient rather than in front of my computer going back and forth with all this messaging. So often, patients feel overwhelmed. On the other hand, nurses and providers also feel overwhelmed and kind of struggle through this communication process. And that causes burnout rate as well. There are statistics that shows that healthcare providers are increasingly getting overworked and burdened and even quitting their jobs actually because of this burden. And a lot of it actually comes from their interaction with EHR portals. So this is why we want to kind of address this problem. And particularly in this talk, I'll talk about this aspect where we try to help the patient to craft better message in the first place so that these missing gaps are filled in. So this is kind of ironical because we started the project with idea of triaging the message, which we are still doing, but quickly we figured out this is a two-way street like communication. So we have to solve the problem at patient end as well. So today I'm going to talk a bit more about how can we leverage human AI collaboration in patient portal to help patient craft better messages particularly. So here is an example of a patient message. They're saying they're not feeling great and losing hair rapidly. And the message is very brief, but then when the provider look at their EHR data, they kind of see all this information like their age, their medication. And this is important, like because their medication has chemotherapy medication, which is pretty critical in this case. And that actually changes how they make decision quite a lot. And then they kind of ask back this question, follow-up question to better understand their situation. So the particular problem we're trying to solve here is when the patient is sending the message in the first place, nudge them to include information that could be helpful for the decision-making process. And we call that follow-up question generation process. So this is like a generative task. And we plan to use large language models to generate this question so that patients can send better message in the first place and then get better response, timely response as well. And if we think about from a machine learning perspective or like an NLP perspective, the research question is generate relevant question and rank them. Because, as you probably have experienced working with generative AI, like if you ask it to generate something, it really generates a long list often. Not everything is super relevant or super important. So we kind of formulate the problem as a relevant question generation and ranking. And then we try to see or evaluate LLM's capability to see if they can generate questions that are similar to question generated by a clinician in the same context. So this is a very human AI interaction thing. So we have ground truth coming from patient data, their doctor's data, and then we're evaluating the output of LLMs to see how they align with each other. So here is an example of what it would look like. So for this given message here, people complaining about chills, skin hurts, and then I'm showing some question generated by their clinician in this column. And then on the other column, I have question generated by AI. And the task is kind of finding question that matches the clinician's question, right? And if you think about it, this is a kind of difficult matching problem because it's not going to be an exact match. Even though it's relevant, it's useful, it's not going to be an exact match. For example, these two questions I'm highlighting here, they are similar, or our doctors think that they are similar, but their wording is very different. So that kind of also forced us to think about how do we evaluate this kind of system, where you have generated outputs.
Does the ordering of the questions matter? Because the way that you have it here is the sets, right?
Yeah.
But I would imagine that the ordering would matter.
Ordering matters, yeah. But in our case, we have seen that when clinicians ask the question, they're kind of precise, they hit different points with different questions. So we kind of compare them as a list. But ordering does matter, especially in the AI generated output. It usually gives you like a ranked list of outputs. So then we kind of pick the top 10 or top 5, something like that. Good question. Yeah.
Do we actually need generative AI to ask questions like if you have a fever? I imagine that's probably a pretty common question.
But how many conditions are you going to hardcode? Because I think the question of fever becomes relevant based on what type of diagnosis they have in mind. So we actually, in our dataset, I'm going to talk about the dataset briefly as well in a moment. But in our dataset, we have actually different types of conditions. So fever is definitely relevant for some conditions, but not for all of those.
Sure.
Yeah.
What I really consider diagnosticians are going to look through. Sometimes they're going to have a decision tree that you can go through.
Right.
Why do we need an AI to go through, to do much more than choose which decision tree to go in?
Oh, that's because of the missing context. Because the decision tree you're talking about, I totally agree with you. Like if the message was complete and all the information was there, maybe we could just find what is the best decision tree or what is the optimal process here. But because of the problem of missing context, information is not there, and scattered context. Information is scattered across multiple data tables in the EHR data. So that's why it gets complicated. Yeah. And even and we actually rigorously interviewed multiple triage nurses over the summer. We had series of workshops with them, and we got feedback from them on same question, feedback from multiple nurses and multiple triage nurses. So we realized that this problem is really very, very complex. How the trees are branched, that really depends. There's a lot of situated and contested knowledge there.
Which goes to the ordering.
Exactly. Yeah. I mean, there are definitely some factors that they consider, but the situation gets complex quite quickly. Yeah. So this is our data set statistics that we are currently using. So these all, yeah.
But with the AI methods that you're using, you don't rank the questions that you're generating based on some information gain or something, right? Because when I think about it, in a way, they're going through this decision tree that was discussed.
Right.
And when I build a decision tree, I'm like, okay, I got to fork on a feature that gives me the most information gain.
Right. Yeah.
Something along that line.
Yeah, we actually, when we evaluated the list generated question, we actually found that they are kind of ranked according to importance. We evaluated and the doctors also confirmed that the question that comes in the beginning are usually more important than the question that comes later. Yeah, they are more concise and they are more relevant usually. So the LLMs are automatically kind of ranking them when they are generating that list.
But the ranking is not ordering though. Right. So the ranking is just okay, ask this first.
Yeah.
But it's not an order.
It's not ordered. Yeah. I mean, when we're evaluating, we're kind of considering it as a list. Yeah, not as an order. Yeah. We haven't evaluated the ordering part yet, but right now it's more about, okay, the clinicians ask these 5 questions. Can AI capture this question in the first 10 or 15 questions? Yeah. So this is the data set we are currently using. We have over 600,000 messages from Dartmouth Hitchcock, which covers a lot of people in northern New England area. Most of these are kind of rural population, as you can see here. We have their, location geocode distribution, and we have over 10,000 patients in our data set. And so for all these patients, we have their linked EHR data as well, because as I said, this is, although the core problem is in conversation, there is a lot of context and information in their structured EHR data. So we have linked EHR data for all these patients. And, we have very diverse, pretty wide set of diagnostic codes in terms of what type of problems our patients have. And from the patient perspective, for a patient, these are the kind of data we have. So we have their patient messages, their prior medical encounters and diagnosis with the system, their problem list, kind of as in ICD codes, medication history, demographic information, but we also have this communication information, did they call the doctor's office? Because those are also sometimes important, somebody messaged and maybe called the doctor a few days ago, that's also relevant. Did they have any emergency visit or hospital visit, their PCP visit or provider related information, who took care of them at that time. So it's pretty comprehensive data set and very, very, very helpful to kind of solve this kind of problem, because these are not just on messaging, these are kind of expanded to other modalities as well.
Does the telephone encounter history actually captures the text that was communicated, or is it just that Tina called 5 times on Monday?
Tina called 5 times on Monday and some notes as well, for this, for that, for a fever. Took, yeah. Whoever attended the call, yeah, they took the note there, yeah. But we figured that that's also important. We actually talked to the physician team before getting access to all this data, which fields would be relevant for us. Yeah, and thankfully we got our hands on this expensive data set. But then I'll now briefly talk about the experiment setup. So because as I said, the ground truth labeling is kind of complicated here. So we had to look into the clinician's responses, the back and forth, and see for the sent messages whenever the clinician asked a follow-up question. So we basically focused on those messages that has a follow-up question from the clinician. And usually it varies the number of questions, from 1 to 14, usually somewhere close to 3 questions per query or per message. And then now, like going back to the in-context learning, so we did apply in-context learning for this problem, like prompting LLM to generate follow-up question. And for in-context learning, we actually tried 3 different setup. One was zero shot, where we just explain the task to the LLM. We don't give it any example or any demonstration example, just describe the task and the levels. Few shot was like we tried with k equal to 3, where we kind of give 3 demonstration samples, chosen from the data set. And for the other setup, retrieval augmented generation, so we actually use RAG or retrieval augmented generation to find semantically similar matching, like, using SBART for prompting the LLM or interacting with them. And with all of this prompting strategy of whenever we are sharing sample messages, we also share the age, gender, like, because these are very relevant factors for making that decision for that particular patient. We also share their medication list, problem list, their diagnostic codes, and all these things. And sometimes medication list could be really long. Some people have 30, 40 medications gathered over the year. Usually we consider the top 10 because they are like top most recent 10 medications that were relevant. Yeah. And for the evaluation metric, like how do you compare the performance of the LLM? So we use this measure. This is kind of similar to recall. So where we see, okay, between the L is the list of questions asked by an LLM or generated by an LLM, and C is the set of questions originally asked by the patient clinician, and then we see how much overlap is there, the rate of overlap between these two sets. And we don't penalize LLMs for generating more questions because we kind of scheme like, the top 10 or top 15 question from the generated question and then kind of see if there is a hit. But that is something definitely we plan to explore in the future, like coming up with a metric that also controls number of questions being asked. Yeah,
Sorry, so
sure.
When you are saying that they intersect, so do you, what kind of a screen distance measure do you use?
That's a great question. So we actually did both evaluation here, and I'll get to that in a minute. So for comparison, we did it first we did it manually. Like we had students and clinician team where they looked at the question asked by LLM and then question asked by clinician, and they kind of give us a score. Oh, this is a match, this is not a match. But as you can imagine, that gets intractable very quickly. You got a very good question, Tina. So we actually also came up with an auto evaluation mechanism where we actually use a fine-tuned LLM to compare these two phrases or two questions and use that for automatically evaluating part of the data as well. Yeah, because only manual evaluation makes it very difficult to evaluate on a larger set. It takes a lot of time for humans to kind of come up with perfect ground truth. But thankfully, when we kind of break down the problem into smaller problem, like LLM comparing whether two questions would invoke similar response. So when we say comparing, we are not just comparing string wise, we're kind of comparing based on the answer, like whether this question and this question, whether they will elicit similar response from the patient. We actually consider that for comparing. Yeah.
All right.
Yeah. We started with the thought of finding similar phrases or similar question, but then our doctor, they gave us a very good quote. It was like, it's close enough, it's very close, but not close enough. So we kind of went back there, like whether the responses would be similar. Yeah. Thank you for asking that. For example, here, do you have any fever that clinician was asking, and then AI asking, do you have a temperature over 100.4? So the doctor was like, yeah, this is a good question because when somebody says they have a temperature over 100.4, we consider that as a fever. So that they would kind of elicit similar responses, although the semantic similarity might not be very high. Yeah. But this is also like an open question here, like how do you compare these two? Right?
You have something like if you, the RIM measure,
yeah,
you had two different conditions.
Right.
So you know what the metric would be, right?
Yeah, you have asked a very good question, like how much agreement there is between between two clinicians. We actually did some evaluation. I don't have the numbers on it yet because this is still a work in progress. But they don't always agree 100%. On this follow-up question, like I would ask this, I would ask that. And we also saw that in our data, like patient with similar background, similar question, but the response from the provider is not exactly aligned. So I think that's also make it an interesting problem to solve through the human AI interaction angle, because even within human, there is not always consistency. So by AI, if it generates like a large number of questions, it might kind of cover reasoning from two clinicians and ultimately be more helpful. Yeah. Yeah.
I know in other, because
Yeah.
doctors are noisy.
Yeah. Yeah.
And in other applications, instead of like showing a bunch of ophthalmologist images of eyes and saying, does this eye have disease?
Yeah.
Showing them two pictures and saying which one is more likely to have the disease. And then they get better labeled data, and you need fewer labeled data.
Right.
I don't know if we can use something like that here.
That could be interesting. Yeah. Exactly, like discriminating factor from like by looking into multiple related sample, not exactly the same, but kind of learning to distinguish between those. That could be interesting. Yeah, yeah. So honestly, like we have been doing it for the last couple of years, like getting the data, making everything like work, because it's in a secure virtual machine, given the privacy like concern of this data. So it kind of took us some time to get the setup ready, but now we have a clinician team like, working with us consistently. So we definitely plan to explore that in the future. Great question. Thank you. Yeah. So going back to our theme of like how does in context learning work in this case, and I hope that you are convinced this is a complex problem, even for clinicians and even for providers. So we tried zero-shot in context learning, where we're not giving any specific example. We're just telling them the task. This is the task. For few shot, we tried with 3 different sample, and then for RAG, it's like finding 3 matching sample from the data. And surprisingly, so we tried only these open source LLMs that we could try in our secure machine for this data. And among these, we found that actually zero-shot overperforms the other methods, which was a bit surprising, because if you read in context learning papers or survey, usually few shot works better than zero-shot learning in most of the settings. But this was surprising, and later when we did qualitative analysis of the data, we kind of had some hypotheses of like why this happened. For example, not having a good sample to show that sometimes hurt the performance. Like the model gets overgeneralized or kind of biased towards the sample that was chosen. And also we figured out that the RAG technique, which worked in many cases to find relevant sample, also needs some improvement here, because the data is kind of scattered. It's not just message, there is also structured EHR data. So which tables to look into, how to find relevant information. So that's something, some of our future work as well, like how can we expand retrieval augmented generation to work with this kind of system where you have data that is fragmented across multiple sources.
So why did you choose to use like general purpose LLMs? I know there's an issue of privacy, blah, 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 but you would expect that, like, if I have an LLM that's trained on medical stuff, right? Like, for example, there are these LLMs like Harvey that's for law, right? Then you would get better recall.
Yeah, the Llama Allo is actually health specific. Yeah, it is. We are not still sure, like, why doesn't it do very well? And our results were not very statistically significant either, like this performance between multiple models. So we plan to explore it using more data, like, so right now we have used, I think we have evaluated close to 1,000 samples, but we plan to expand that and have like result that will be more, convincing for sure. But one of our hypotheses is like, maybe even the model like Llama Allo, although it is specific to healthcare, maybe it's not particularly tuned toward this kind of fragmented system, something like that. But I mean, overall, the results are not super convincing to me. Like, the numbers are still pretty low, like, if you think about similarity. So I feel like we still have a long way to go to kind of address this gap. Yeah.
But maybe it is a task that you cannot get 90%.
Yeah.
There are certain tasks
Yeah.
fraud detection, you're lucky to get 20.
Yeah. No, these are great question, and definitely food for thought. So this was like number wise, and number wise the performance of different LLMs we have tried for this particular task. And then this is like this is a sample output from LLM. So qualitatively, like, some of the AI generated follow-up question like the first two, the doctors were like, yes, that makes sense. So we, instead of just like the number, we also wanted to see the qualitative aspect of it, because something Baron mentioned earlier, like, do clinicians agree with each other? That's actually another thing that you have seen, that even within the ground truth, it's noisy. So we also wanted to see that how do the triage nurses and provider like, rate this type of output. So sometimes they are like, oh, this is a good question. When was the last time you were seen by the provider? They are like, no, it's already in the EHR. I'm not going to ask them that. And then also, are you taking any medications? They are like, okay, this is too vague. I won't probably ask, like, I would ask more specifically, are you still taking your Tylenol? Are you still taking that particular medication? So there are like, different factors, like stylistically, their prior knowledge and experience coming from years spent on this work, where LLMs, we didn't really do a lot of fine tuning of these LLMs before generating this follow-up question, which is kind of something we plan to do. Yeah.
So I guess there's an assumption, so if you're measuring similarity of questions based on answers, there's this assumption that like the answers you're going to get per question are going to be similar.
Similar, yeah.
But maybe it's not.
Yeah.
Right?
Yeah.
Like, because in particular, because your population is probably homogeneous. If you have a heterogeneous population, you may have different responses to questions that are similar.
Yeah, yeah.
So, I don't know.
Yeah, we have also been thinking about that. So that kind of brought us to thinking about the similarity measure, even like how do we compare similarity measure between text? And we have some ongoing work there as well. But you are right, like how do you capture the semantic similarity or kind of similarity of responses there? That's a thing. Like, are they even on the same topic? Or are they even from the same category versus like different categories? Yeah. And we also compared like, for these different type of models, how much of they like, they overlap with the doctor's, the question the doctor asked. So only 13% of the cases, they ask all the question by the doctor. And note that although the LLMs actually generate a longer list of questions, and even within that, only there is like 13% of them answer all the question asked by the provider. So something Tina mentioned earlier, like how do you evaluate this thing? So it was very challenging to evaluate these generated questions, because manually verifying them is very, very time consuming. Like we're not only looking at the semantic match, but also whether the questions would elicit similar responses. So we developed an auto-evaluation methods to kind of speed up that process. And we did it by fine-tuning LLMs to kind of find like, compare question similarity. And based on our tests, like tested particularly for auto-eval, we saw that it has a kind of a high true positive rate, like, about 87%, and very, very low false negative rate. So we kind of use that for evaluating this LLM generated question, but we plan to make it even better for future iteration and also expand our test set to do this. And in addition to this, yeah.
Like, what are the ideas of how to make it better?
Yeah, so kind of exploring the idea of like when you are comparing question, because we want to compare question that would invoke similar responses. So creating more diverse sample for that, like, whether our question base is like, have lots of question and different types of question, so that it's more diverse and not just homogeneous. Yeah, and I feel like, like many other machine learning problem, we definitely would need more annotated data in this case. And when we started the work, there was no annotated data available. We had to do everything from scratch. But I think getting annotated data from multiple different conditions could be very helpful in this case.
Because I was thinking, like, as a professor or a teacher, when you design an exam,
yeah,
you want to design questions that everybody would interpret that similar.
Yeah.
Right? So
Yes.
I guess that's what you're
Yeah.
talking about, that you want to have questions where like people will interpret it the same way.
Right. Yeah. It won't be like,
so you would get similar answers.
Yeah.
As opposed to different.
Yeah.
Right.
True. And in addition to like, quantitatively evaluating the LLMs, we also did a qualitative evaluation where we asked 5 triage nurses their feedback about our generated question. So we get feedback on like this 4 dimension. One was utility, like will it be even helpful to you? Conciseness, are they really necessary to ask? And then completeness, will it, be helpful to kind of assess the situation the patient is presenting? And then the clarity, like, getting consistent answer from the patient, like, is this message clear enough to elicit, like, good responses? So that I felt like was more positive than just looking at the numbers, because our studies have limitation as well. So overall, we got very good feedback from the nurses. And I know some of them actually said, I would really like something like that in case, even though it doesn't have a high accuracy. And as you were saying, maybe you will not get 90% accuracy. They think it would still save them time, which is really critical. Like, it may not be like 100% like the way I would do it, but I think it would still be helpful. They rated the questions, they rated it well, like in terms of utility, completeness. There are some concern about clarity, but I think that is something we can also further work on. So we plan to kind of get this, like, leverage this feedback to make this model better, not just for in terms of accuracy number or the matching score, but also in terms of like making them more clear or making them more concise.
Cool. So maybe another application would be actually coming up with assignments and exams.
Yeah.
I'm just
professor talking. Yeah. Yeah. For them, right? For the provider, yeah.
Like, in the example you show, somebody's like talking about their symptoms.
Yeah. Yeah.
Have you thought about like the implications with respect to personal demographics? So, for
Yeah.
example, if you ask the question and have comparison accurate, like,
Yeah.
are you worried at all about the disparity in performance with respect to the question generation that you might observe? And also, like, the respect to which the generated question will be thought clear from the perspective of an individual?
Yeah, we haven't explored that much yet, because admittedly our data set is, I think, also lacks diverse representation coming from like, New Hampshire and Vermont. But I think that would be definitely something super interesting to explore. And another success story, I like, for n equal to 1 sample, I actually followed this method, and I had a strep throat and I could barely talk. So I called them, they didn't pick up the phone. So I actually sent them a message, like thinking about all this guideline. And then the nurse called me back and she's like, wow, your message was so helpful. You should do this. So that's just like a personal success story. Like it really helps for patients as well. Like you are kind of communicating information in a more concise way. But that's a great question, Byron. We actually plan to see like how much diverse samples we have. At first figure that part out. And then for like, if we can do some sort of like, control matching, like for similar condition, are there differences based on race, ethnicity, or gender, or age? There is definitely differences in age-based decision that they make, but I also want to see like, if there are other things.
Maybe you should deploy it in Queens, New York.
Yeah. It'd be super cool. Connect me with those, or maybe connect me somewhere here, there it will be more diverse.
The only person I know that was born and raised in Queens is Trump.
Oh no. Maybe you'll not be a good sample. Yeah, thank you. That was interesting. Yeah, but we'll definitely explore that once you have more corresponding data. Yeah. Okay, so I will kind of maybe, because we are a little bit tight on time, but let's see how much you can cover it. So the next question I wanted to explore with you is, how can we use in context learning to improve communication outside of traditional healthcare system? And this is something I deeply care about, because I think often there are many reasons why we don't have access to our provider, or we can't really ping them all the time, right? Like you have specific appointments, so there are definitely access barrier. And I don't even want to get started on the health insurance issue, like whether all people have access to healthcare who needs it. There are also cases where there is a lot of urgency. And there are also cases where there is a lot of uncertainty, where doctors might not always have the perfect answer all the time, right? For example, for many complex conditions like cancer, mental health conditions, or like, substance use disorder treatment, there are many uncertainties in those treatment. And often there is stigma as well, like when people don't feel comfortable or don't trust their providers enough to kind of ask this kind of question. And there are lots of studies showing that how these barriers kind of, motivate people to go to online patient forum and ask their questions there. So particularly we study Reddit, because we did a survey of different health forums and we figured out Reddit has really good reach. And because it's pseudo-anonymous, there is a lot of rich content on very stigmatized and complex topic. And another reason this analysis of online health discourse is super important is also that knowledge is not always very universal. It's very situated and contested. So to give you an example, everyone talks about misinformation, but from my research in the last 3 years, I have seen that for health spaces, rumors are much more complicated than misinformation, because misinformation, you could go and like look into a news article or science article and debunk it. But with rumor, often doctors don't even have answer. They are like, I interviewed them and they are like, oh, I don't have any answer for that. I don't feel comfortable sharing an answer without knowing further about the patient. So there is a lot of situated knowledge. So this is also a super important angle. And, you know, again, this is another area where health communication, if we can effectively analyze the data and like, you know, figure out what type of questions people are asking, what type of answers they are getting, responses they are getting, and the quality of responses, that can significantly improve health outcome and even save lives. You know, I lost my own mom to cancer last year, and she was in Bangladesh at that time, where I'm originally from. And you know, when her initial diagnosis came, I was Googling information and going into patient forum to learn more about it. And then I had an idea like, does she have cancer? You know, and the doctors were like, no, she doesn't have cancer. So it took us a while to figure out that she has cancer, and they even misdiagnosed which stage she was at. So I sometimes feel super frustrated, like, you know, I wish we knew it sooner, because it was very contradictory. Like usually they say don't Google information, it will give you false information. But I felt like in my case, I actually got the right information here, which was very confusing. But anyway, I feel online communities of patients, they actually have a lot to offer to traditional care system because of all these reasons. So I'm also super interested in exploring that space. So how to extract insights from these online communities that can inform traditional care. So particularly the one angle we take here is event extraction. Event extraction is actually one type of natural language processing and information extraction task, where it's much more granular than just named entity recognition or just relation extraction. I'm sure Byron knows a lot more about that. We often cite his paper or event extraction as well. So event extraction basically tries to extract structured information in the form of an event. So here is an example, a very random example from a standard event extraction data set. For example, insect infestation in crops or something, you know. So this is the event, and then it has these arguments or roles, which are like, you know, economic loss, like date, when did it happen, what type of pest was it, like, you know, what caused that infestation. So there is this event and argument structure. So these are rows, and by argument we mean the particular surface form that appears in the text. We call it argument, but they are very linked. So as you can imagine, like, you know, event extraction is very complicated, and thankfully this is an area where LLMs don't do very well. And I'm going to particularly talk about in context learning with LLM for health discourse, but we have also ongoing work where we try to improve LLM's performance for event extraction in general data set as well. So here is an example that is more specific to healthcare. So the reason we want to do event extraction, because it kind of gives you more granular sense of somebody, like what they are asking. Like in this particular case, somebody was recently diagnosed with prostate cancer, and they're seeking help about choosing treatment option, which is a very common problem for cancer diagnosis and treatment, by the way. And in existing current event extraction paradigm, there are these limitations where they are not often suited for, like, you know, online discourse. Like most of the data set they are from like Wikipedia or news article. We are citing Byron's paper. I think Byron has a paper on health related event extraction, but I think that's a very less explored area in general. But it has also a lot of potential. For example, by looking into the granular information level, if you are extracting from event, you can actually do very thorough opinion mining, like perception about different treatment option or treatment experience. It can be very useful for question answering. It can be very useful for rumor and misinformation detection as well, because it kind of gives you a more granular view, which are very important for this type of task. So one limitation of existing event extraction. So there are standard models, standard NLP models for event extraction, but they all make this assumption that all the arguments are explicit. For example, here somebody mentioned I'm 46 and I have been diagnosed with prostate cancer. So these are explicit arguments, but there are also implicit arguments. Like from it, you can infer that they are male. The treatment option they are seeking is like one type of, prostate removal surgery. And there are also scattered arguments, which makes things also very complicated because not everything is said at once. Like, the span is kind of scattered. And existing event argument extraction kind of make the assumption everything is explicit and they are kind of, closely knit together, which doesn't happen in real data, especially in online discourse. So we reformulate this problem as a generative extraction problem. And this paper has recently been accepted to EMNLP. We're going to present it next month. And in addition to formulating as a generation problem, we also try to capture implicit and scattered argument from this kind of complicated discourse. So here I'm showing the annotation of implicit arguments and unscattered arguments. So it kind of helps to understand how LLM can be helpful in this space. And generative extraction is also meaningful in this case because not everything is going to be expressed. Like when LLM extract it, it can be expressed in a different way, although it could be correct. So we kind of want to be mindful of that. And we particularly chose as a use case this discourse from opioid use disorder because this is regionally a very important problem. And this study was also kind of motivated us to work for this grant at NIDA. Which is relevant to them. And but the findings I feel like we actually plan to expand it to other discourse because we have seen that happening in many other online communities as well, not just for opioid use disorder. So we have come up with this. Sorry, let me get rid of this. Yeah. So we actually come up with this new data set for event extraction and also benchmark where we benchmark LLM for this task, how good they are for this kind of complicated event argument extraction. And we developed a new ontology to capture this event and their argument structure because this is a very complicated space in terms of argument. And our annotation resulted into over 7,000 event argument annotation. And this data set is actually publicly available. So if you go to this paper, we have it on archive now, and we have actually a project website hosting all the prompts and data set developed for all the codes developed for this project. And part of the motivation was also make this research very reproducible and share with the research community as well. And this is our discourse ontology, discourse event extraction ontology. So we have 3 events here that are specific to treatment for opioid use disorder. And then the events are taking this medication for opioid use disorder. Return to usage is also a very common event for people in recovery. And tapering is also common, but also very less explored in clinical literature. And this has also clinical relevance because when we're working with the clinician, they are like, oh, we don't get this information from traditional sources like EHR or patient survey, where people might not feel comfortable sharing all this information with their provider, but they are more willing to share it on online spaces. So in addition to information extraction, it also has this knowledge discovery angle that it helps clinical researcher to better understand patient behavior and what they do when they are come up with challenges. And in the argument space, we separate it as core argument, and then we also for each core argument we also see there are type specific argument in this space. So we came up with this ontology and annotated this new data set for this kind of online discourse. And I don't want to scare you, but here is just annotation for one sample. So our annotation is kind of, coming from the information seeking post and advice containing comment. And then we have this kind of tuple structure of event and argument role for this question answering pair. So this is kind of a complicated version of a question answering data set, but we felt it would be really helpful to kind of do granular analysis of this kind of discourse.
So maybe I missed something.
Yeah.
So to do this task,
Yeah.
this is a supervised task. Your ontology is the label. So
Yes.
you have data that has been labeled with that ontology.
Right.
Who did that label? Like a person.
Yeah. Yeah. Multiple. Yeah. We recruited and trained the annotators. Yeah. Yeah. So in order to solve that problem, we actually tried different solution. I'll show you in a minute. So we tried, so event detection is basically at first you detect which event is mentioned in that particular sample. And then event argument extraction is okay for a given event, what are the arguments mentioned in the text. And we actually tried, transformer-based models, and then instruction fine-tuned models, and also in context learning with large language models to see different variations of it. And then here are the performance from different models we have used, and this is just for this multi-class classification of event detection. So as you can see that even with state-of-the-art models like GPT-4 for event detection, it got the high score, but it's like close to point 61. So not like this, there still needs a lot to be done in this space. This is like a complicated problem. And then some of the instruction tuned model were close to these LLMs with zero shot prompt. And interestingly, again here, like when we tried few shot prompt, that actually was worse than zero shot prompt. So I'm not showing it here, but we also feel like in the few shot space, we need to explore more because there are so many things that you could vary, like the prompt template, the demonstration we select, which is also subject to our current research, like how do you select this sample? But we kind of pose this as an open research question for the community. And this paper, we got into EMNLP, happy to share with you if you're interested. Yeah.
So yeah. What are like high numbers for event detection? Like how do these in general stack?
I don't remember on top of my head, but in this case, it's kind of difficult to compare it with the state-of-the-art event detection model because the state-of-the-art event detection model doesn't capture, they are usually from news article or Wikipedia, so where the text is very different.
Right.
Yeah.
But how well do those do on event detection?
On this case, yeah, I as far as I remember, they didn't do very well, not even close to the fine-tuned transformer-based model, like far off from that. We did try those in the beginning, but then we figured the fine-tuned transformer-based models were much better than the kind of state-of-the-art. And that also kind of relates to our point of like how difficult this text is to process. Like often the event mentioned may not be direct here as well. And the problem is even more complicated for even argument extraction, which is like, you have to kind of extract a span of text from the given input. And here we tried extractive question answering model with BERT, fine-tuned, and this is one of the state-of-the-art for even argument extraction, by the way, this first model. And then we tried our generative question answering based model that we formulated. And then we also tried zero-shot prompting, zero-shot in context learning with large language models. So there are two variations we tried. The first one is description guided, where we provide description for each argument or role that is present. And for the question guided, we kind of pose the description as a question because you could be like, oh, when did this happen? Where did this happen? So kind of just flipping the way we formulate that. And so another problem, again, because we are kind of going to the generative extraction part, exact match doesn't always work. So for example, somebody complaining about runny nose versus drippy nose, they are not same. So similarity score could be low. So we go to relaxed match where we have a similarity threshold. And if their similarity is over a certain threshold, we consider them a match. And we manually evaluated some of these generated sample and see that, this works better than just exact match. And here are the results of in context learning in zero shot. With large language models for event argument extraction. And we saw that the description guided prompt works slightly better than the question guided prompt. But again, this is a very gray area where we definitely would need more research. But our point was to show that this is a very complicated problem that you can't just completely solve using even state-of-the-art large language models. And then also, even if you give them in context, more demonstration, few shot in context, they actually work worse than the zero shot one. The model gets super biased by that. So we have some ongoing research on how can we improve this technique. And from that research, we see we need to look at the evaluation metric as well. It's not just using standard metric, and also capture semantically outlying roles in this space as well. So since we are kind of pressed for time, I'm not going to go like over all the details that I have to improve in context learning, but I'll give just like a quick overview here. So our idea to improve was improving the demonstration selection process for few shot, because as I said, like few shot processes often suffer, which is counterintuitive. So we have some ideas to find more representative samples. And the way we came up with it was like, we wanted to try the text within a corpus, think of it as your training data, and figuring out samples which are more representative in that set. So we tried with this technique called depth-based embedding. So we kind of take the transformer embedding for all the samples and we try to rank them based on representativeness. And then we pick the most representative sample, like from the top of the rank, like ranked list, and use that for in-context learning. And this paper was published in EMNLP last year. So the idea is basically, if this was your training data and then you are kind of setting a score for all of your sample, indicating how representative they are of the overall corpus. And then the idea is if we select the top N sample for demonstration that are more representative, they would probably improve the performance of in-context learning. So in our, this is what the kind of ranking process looks like. So we come up with a depth score for each of the text embedding of our sample, and F is it indicates the overall corpus. So it kind of gives you score for each sample, and then we use the depth score to pick more representative sample. And so we try depth-based sample selection, and we compare it with baseline like random sample selection, and label distributed matching is you make sure the label distribution in training corpus is maintained in the samples you select for in-context learning. And then we also have a version where we combine depth first and distribution-based matching. Yeah.
Maybe a dumb question. If
No.
you have all this data that you're selecting from each example, why don't you just fine-tune all the data?
We could definitely do that. Yeah, we could definitely do that. But the idea was like exploring from the angle of in-context learning. Like, can we use that to improve in-context learning based approach? But it could also do fine-tuning as well. Yeah.
Okay.
If you could wrap up.
Yeah, sure. So just a quick idea here, like we saw that in our initial exploration, so we looked into more generic NLP tasks like, paraphrase rejection, sentiment classification, entailment, and there we saw overall depth actually helps to find more representative sample, and the results are statistically significant that I have shown here overall, but we will plan to explore more this for our kind of task-specific setup to improve in-context learning for the task I mentioned today. So here are some ongoing and future work. We plan to do kind of improving the methods and also the measures for in-context learning to see how it can improve AI-based communication tools. And yeah, so these are the key points I wanted to make today. That human-AI collaboration is critical, and we have many applications in mind facing patients, provider, and researchers. And in-context learning with large language models can be helpful, but there is still a long way to go there. And I want to finish this talk by thanking my amazing students who did all this groundwork here. And we're also thankful for the research grants that sponsored our research. And I'm very thankful for all my amazing collaborators as well at Dartmouth and outside to explore these questions. Yeah, thank you so much.
Thank you. Question? Or one, long one. I guess one quick question. One quick question is, I didn't really get the HCI angle of it.
Yeah.
I got the NLP angle of it.
Yes. The HCI angle, I didn't have much time to present here, but some of the results, we have papers under submission. So where we basically see the applications we have in mind. So how do we evaluate those with actual human and whether they are helpful. So there are definitely HCI questions we have been exploring in terms of finding the usability of this tool, the effectiveness of this tool. And I feel like there is also this open question about how do you incorporate their feedback in the evaluation process as well. Yeah. Sorry that I could not cover a lot of those. Yeah.
Great.
Thank you.
Thank you very much.
Thank you.
Why don't we wrap up?
Yeah.
I think maybe Kim is now sick.
Sure.
Thanks, Byron.
Thanks.
Thanks for the
Thank you. Thank you.
And the
Yeah. There's slices of all. The seed, that looks plausible. But you don't want to see it?
and then I'll
Yeah.
sure that we have this the mic.
Oh, right. Yeah. Sure. Yeah.
That was great.
Thank you so
As
much,
I said,
Tina.
we asked questions.
No, that was
So,
very helpful.
mm,
actually set for.
all right. Because I don't think Kim was able to attend your talk,
Yeah.
so I did send him an email.
Yeah.
Although for the most part, all of things ahead of them, model. Oh, yeah, we still need to show her. We just put in the other sugar now. So,
Yeah, I think we have some number of cited